Hey guys, it's Dr. DeShavo. I'm back playing a little Your Body's a Wonderland because it truly is, and it's just miraculous everything it does and how it all works. So we're moving on to kidney physiology. And if you have any questions, of course, please let me know. And we've already gone over the anatomy, and the anatomy is or was reviewing some of those basic structures, but it's really important to understand not only the gross anatomy of the kidney, also the microscopic anatomy of the kidney, because that's truly what makes it all happen with the kidney, is the microscopic aspect, okay? So let's move on to kidney physiology or the function. Kidneys work, kidneys work. 1,200 milliliters of blood passes through the glomeruli every minute. It's amazing. Okay. Normal filtration rate is 180 liters per day over 24 hours, okay, on average. Kidneys use, and this is pretty astounding as well, 20 to 25% of the body's oxygen. They're really what we call metabolic. They're going to use a lot of oxygen, a lot of glucose to create that energy. Now, there's going to be, and if this doesn't sound familiar, please pause this, go back and review the kidney microscopic anatomy. We need to remember that there's that glomerular filtration. So we filter through those glomerular capillaries. We'll then take that filtrate, or the beginning of the urine, put it in that capsular space in that Bowman's capsule. Then it starts to move its way through those tubes. And along those different tubes, the proximal convoluted tubule, the loop of Henle, the distal convoluted tubule will have different substances reabsorbed in different areas. Now, if a substance is totally not reabsorbed, it'll be secreted into that tube, okay, and secreted as urine. Okay, so glomerular filtration, tubular reabsorption, and secretion. And we have two choices. It'll either go back into the systemic blood flow through those capillaries, or it'll be excreted as urine. Okay? If that doesn't sound familiar, please just review it. Okay? Glomerular filtration. So the pressure of blood, this is actually a passive process, glomerular filtration. It's not active. We don't have pumps that are on that membrane that'll be activated that'll use energy to pump these filtrated substances through. It's passive. So it really depends on blood pressure. And that blood pressure, as you know, is going to create perfusion. It'll cause substances to go across that glomerular, excuse me, capillary membrane into that space. So it's got to be a fairly high pressure rate, not compared to systemic blood pressure, but that rate is 55 millimeters of mercury. That's not negative. That looks like a negative. It's not. So it's a fairly high pressure rate. Small molecules will pass freely. Okay. And then we have something that helps to regulate glomerular filtration rate. We have intrinsic controls. And intrinsic controls are simply the smooth muscle that are in the arterioles that feed blood into the glomerulus, or that whole renal corpuscle. And if you think of it this way, I always think of this analogy. In the summertime, if I'm watering my plants and I'm out with my boys and they're driving me a little nuts and I want to blow off some steam because I'm mad at them, I'll turn the hose on my little boys. Not heavy. Don't think that I'm hosing them down. I just spray them a little bit. Okay, get them a little bit wet, and they love it. They love getting wet in the sunshine. But if I need to get them far away, I need to increase the pressure of flow through that hose. So I'll cover half of that hose with my thumb, and it'll increase the pressure rate, right? We have smooth muscle in the arterioles that feed the glomeruli, and we can constrict them or dilate them to change the rate of blood flow to the glomeruli. Okay, and those are intrinsic controls. Okay, now extrinsic controls, and we also have the whole mechanism. I forgot to mention that. Okay, so JG cells will sense a decrease in blood pressure. It stimulates the whole renin-angiotensin system. Okay, now sympathetic control is part of what are called extrinsic controls. These are controls outside of the kidney. They're extrinsic to the kidney. if we sense our pressure is getting too low in the kidney, we can also stimulate the sympathetic nervous system. That'll cause an increase in blood pressure in the body, because sympathetic is fight or flight. That'll increase the blood flow to the kidneys as well. So our body has two mechanisms, intrinsic and extrinsic. Okay, so renin-angiotensin mechanism, those JG cells that we looked at earlier, if they sense pressure is getting too low, those JG cells will release renin. Renin goes into our systemic bloodstream, okay? And what that will do, and there's more steps than this, but I'm trying to keep it somewhat simple, is it will convert angiotensin into angiotensin 1. I don't have it listed there. It's kind of just inherent if you say angiotensin that it's 1, but you could put a 1 there if it helps you. Renin converts angiotensin 1, or begins the process of converting angiotensin 1 into angiotensin 2. And that process is really completed by angiotensin converting enzyme. Okay, so angiotensin converting enzyme is an enzyme that will convert angiotensin 1 to angiotensin 2. This is part of that whole renin-angiotensin mechanism. Okay, and renin helps to facilitate that process, but and the reason I'm pointing that out is because this is where ACE inhibitors will happen. Okay, ACE inhibitors are medications that will stop angiotensin converting enzyme, also known as ACEs. Angiotensin converting enzyme stops ACEs from converting angiotensin 1 to angiotensin 2. Okay, angiotensin 2 is a very, very potent vasoconstrictor, reabsorber of water. This is all listed below. ADH releaser, okay, and it stimulates thirst receptors in the hypothalamus. Okay, angiotensin 1 will do this as well. It'll do those things. It's just not nearly as strong as angiotensin 2. Okay, angiotensin 2 is very, very potent in increasing blood pressure. Okay, so angiotensin 1 does as well. Angiotensin 2 is really the one that's really important for doing that. Okay, it'll cause vasoconstriction, which causes systemic raise in blood pressure, reabsorbs water, sodium, as well as water. It'll stimulate the release of antidiuretic hormone, will reabsorb water into the system. That'll increase the amount of pressure or fluid in the cardiovascular circuit. It'll stimulate thirst receptors in the hypothalamus, so we intake more water, and it'll finally release aldosterone from the adrenal cortex. The aldosterone is a hormone from the adrenal cortex that will also reabsorb salt in the kidneys, and that will also reabsorb water. Okay, it's a mineralocorticoid. Its focus is on those salts. Okay, so renin-angiotensin mechanism, very potent increase in blood pressure. Tubular reabsorption. So along these tubes, we have total blood filtered every 45 minutes. Different areas are going to absorb different substances. We're not going to get into real specifics. Let me see, do I go through? Sodium and water are reabsorbed in all areas. Proteins, cations, ions absorbed in different areas. I don't really get into the specifics. Glucose is usually reabsorbed in the proximal convoluted tubule. That's an important one to know. Okay, non-reabsorbed or poorly reabsorbed substances are urea, creatinine, and uric acid. As a matter of fact, you probably know that creatinine is used to mark kidney excretion. Creatinine is 100% excreted, so people are given that substance, and 100% of that should be excreted through the kidneys. Okay, it doesn't get reabsorbed at all. Same with urea and uric acid. We want to get rid of those because if we reabsorb those, they can turn back into ammonia. Okay, so tubular reabsorption. The only thing I talked about specifically is glucose being reabsorbed in the proximal convoluted tubule. And the only other thing, do I talk about? I really don't. Okay, never mind. Don't worry about it. I won't ask you specifics unless I mention it in the early ones or in the future slides, okay? So, tubular secretion. Kidneys are huge in balancing acid base. And keeping it really simple, okay, the two substances that the kidneys will either secrete or reabsorb when dealing with acid-base are going to be hydrogen and bicarbonate, okay? Hydrogen is going to obviously be more acidic, okay? So hydrogen is acidic. So if our pH is too acidic, we're going to want to get rid of that hydrogen, okay? Bicarbonate is HCO3 minus. HCO3 minus. I don't have the ability to put that little minus subscript or superscript actually would be. So please make sure that you realize that HCO3, it's not a dash after it. It should be HCO3 minus if you want to move that up a little bit or make note, okay? Is bicarbonate. Bicarbonate is basic. So if we're too basic, we're going to get rid of bicarbonate. And these two actually work antagonistically with each other. Okay, so if we're too acidic, we're going to get rid of hydrogen ions and retain bicarbonate. If we're too alkalinic, we'll reabsorb bicarbonate and get rid of hydrogen and vice versa. Okay, so tubular. Concentrations of solution in the kidneys. As filtrate moves through these tubes, so if you look at the right, this is a little picture of, let me get my draw going here. Excuse me. So as we look over here, this is going to be the renal corpuscle. So this is the beginning of that whole system of tubes of the nephron. Okay, if substances stay in that tube, they're eventually going to end up in this collecting duct, and they're going to leave as urine. Okay, go into the calyces and then the renal pelvis and go out through the ureters to be excreted as urine. Okay. You could see different substances will leave at different areas. Water will leave the descending limb. Okay, and you could see it. They have little arrows drawn here. Okay, so as water or as filtrate goes through these tubes and it goes down, it's going to get more concentrated. It actually goes from 300 milliosmoles to 1200 down here. It gets more concentrated. But then as it starts to go back up, you can see sodium is going to leave. Here's the sodium leaving, okay? And it will create a much less concentrated urine, about 100 milliosmoles, okay? So water is going to leave that descending limb, sodium leaves the ascending limb, okay? And then urea is going to leave the descending limb as well, okay? And you get more concentrated urine once again. Okay, so I really won't get into that much with you. Okay, when we get, excuse me, into the tests, but just realize different substances are going to leave at different areas. Okay, different substances will leave at different areas is the main thing to take from this. Dilute urine versus concentrated urine. You all know this. This is, easy peasy. Okay, dilute is obviously going to have less, it's going to have more water in it, so it's going to have proportionately a less concentrated solute in it or substances in it. Okay, concentrated urine is going to have less water in it. Okay, it's going to be more water removed. Now, this is controlled though by the release of antidiuretic hormone. This is going to be the important thing to realize, okay? Antidiuretic hormone is going to help to release a substance called aquaporin in the collecting ducts. And aquaporin is, I imagine, an enzyme, I think, that will help allow those collecting ducts to be more porous. So water can leave the collecting ducts and go back into the systemic bloodstream. Okay, so let's go back a slide here. Oh, that's down. Let's go back a slide here. Okay, I just want to sort of clarify something because people I know get a little bit confused about this. Let me clarify something. Okay, so our blood starts to get filtered. We create the beginning of that filtrate. That filtrate starts to go into these tubes. Okay, it's going to go through these tubes. Different substances are going to be reabsorbed in different areas. Okay. If substances stay in this tube, it is going to go into the collecting duct and eventually it will be urine. Okay, it's going to continue on out and will become urine. Okay, substances that leave this tube, okay, such as water here, sodium here, urea here, are going to go back I'm going to make a mess into peritubular capillaries, okay, which are surrounding these whole tubular networks of the nephron. Those peritubular capillaries are going to take those substances and put them back into the bloodstream, okay? Now, antidiuretic hormone is going to open up pores into these collecting ducts through I believe it's an enzyme called aquaporin, okay? Water will leave and it will go back into those peritubular capillaries, because once again, we have peritubular capillaries here. It'll go back into the systemic circulation and cause an increase in blood pressure. That's the whole purpose of aquaporin, to reabsorb that water, put that water back into the systemic circulation so we can increase pressure in the circulation. Okay, that's the whole purpose of aquaporin. Okay, so moving back down here. Whoops. So ADH will open those pores in the collecting ducts, allowing water to travel through. They'll go back into that systemic circulation. Okay. And that'll create a more concentrated urine because it's going to remove water from the urine. Okay. Now, diuretics are going to stop talking about a totally different subject because it sounds like it's kind of continuation. It's not. It's going to stop reabsorption of sodium at the distal convoluted tubule. This is where diuretics are going to work. So this is one of the few examples that I do want you to know where different things work at different parts of that tubular system. Diuretics are going to stop the reabsorption of sodium at the distal convoluted tubule. Sodium is going to stay in that tubular system. Water will stay with it. It'll be excreted through the urine. Okay, we'll increase the amount of urine. We'll decrease the amount of water in the cardiovascular circuit. We'll decrease the amount of pressure in that cardiovascular circuit. Okay, so diuretics, once again, are going to stop the reabsorption of sodium in the distal convoluted tubule. Sodium is dumped into the ducts or the water or the tubular system in the nephron. Water will go with it. That'll end up in the urine. Okay, please let me know if you don't get that. People for some reason have difficulty with that. I want to make sure you do understand it. Now, renal disease. Okay, so renal disease can happen at the glomerulus or the tubules or both. So we're going to go through some examples of this. Glomerular disorders. So several names of glomerular disorders are well known. There's acute, okay, which would be occurring quickly. Chronic would be long-term. Diffuse, which would be multiple areas, or focal in a specific area, but they're all glomerular nephritis. Okay, so an inflammation of that. Can't be an immune mediated destruction of the glomerulus. Okay, so some sort of like staph or strep infection can get into the systemic blood. It can actually damage that glomerulus. Or it could be specific antibodies that will destroy that basement membrane. So we can develop antibodies and they will go and they'll actually destroy the basement membrane of that glomerulus. And this is generally an autoimmune disease. Okay, that'll cause an immune response and that'll specifically attack the glomerulus. And what'll happen is you can get a lot of scar tissue. And if you look at the surface of that kidney, it'll look really lumpy, bumpy, because you create these focal areas around the glomerulus of scar tissue, and you don't have nice, healthy kidney tissue anymore. You get damaged scar tissue. You can also get microthrombi or little teeny tiny blood clots, which can block up the blood supply and damage it that way as well. So what the result basically is damage for the ability of the glomerulus to filter substances, which is bad, okay, because we need to be able to filter all these substances out. So nephrotic versus nephritic syndrome, these are very difficult to understand, but I think really what to remember is with the nephrotic syndrome, you're going to have damage to that basement membrane, or those foot processes, those cells that cause the interdigitation that surrounds the glomerulus, those can be damaged as well. And what will happen is you get proteinuria. That's the main thing to remember. And I gave you a little website that tells you the difference between them, okay? Proteinuria is going to be a pathognomonic sign for nephrotic syndrome. And one way to help remember that correlation is they both have O's in them. Ooh, proteinuria, nephrotic syndrome. Okay, so that damage to that basement membrane of those foot processes, they're not able to keep the proteins in the bloodstream anymore. They sneak out between those damaged areas of the basement membrane or foot processes, and we get a dumping of protein into the urine. Okay, that loss of protein will cause a systemic hypoalbuminemia. I cannot talk today. Albuminemia, leading to systemic edema. So albumin, guys, is going to help to keep fluids in the bloodstreams. That's the main process or purpose of the liver creating albumin, as you know. If we start dumping that albumin into the urine because of damage to that basement membrane, we will get a decrease of it in the bloodstream. We will lose the ability to keep fluid in the bloodstream. It'll start to leak out through the capillaries, and we get a systemic edema. Okay. Hyperlipidemia may be due to a decrease in plasma proteins. These plasma proteins are able to sop up that excess lipids and return it back to the liver. If we don't have those plasma proteins to do that, we'll keep liver or see, I can't talk today. We'll keep lipids or fats in the bloodstream. We won't be able to get rid of them. I've also seen they just don't know why it causes a hyperlipidemia. Okay, so but it does cause a hyperlipidemia. That's another pathognomonic sign of that nephrotic syndrome. Okay, nephritic syndrome is inflammatory changes that allow red blood cells to escape to the urine, hematuria. Okay, so that's a difference. It's not going to be the proteinuria, it's going to be hematuria. And so red blood cells will sneak out there. Okay, you'll also get a decreased urinary output. You get a swelling of the glomerular area, and it won't allow blood to be filtered and urine to be created. Okay, so you get a decrease in urinary output, and what little bit of urine we get red blood cells out. Now, because we're not getting rid of urine, we get a buildup of those nitrogenous wastes in the blood, azotemia. Okay, that's not good, right? Uric acid is going to build up. We could get more ammonia in the body, and that's a bad thing. Okay, there's going to be less demands on those tubular cells because they're not filtering that filtrate, which is the precursor of urine. They can atrophy and eventually scar. Okay, hypertension can happen because there's a decreased filtration in the glomerulus. The glomerulus senses that. It triggers the renin-angiotensin mechanism. So it'll cause a hypertension, and then that'll get very cyclical. Okay, so I basically summarized it all, but there's a great website that lists the comparisons and the differences. Okay, so tubular interstitial disorders. Okay, so the renal medulla is going to have the loop of Henle, the collecting ducts, and the peritubular capillaries, and there's also tissues between them. And those can get damaged a couple different ways. We can either have a pyelonephritis or interstitial nephritis. That's usually due to drug damage. Too much, Advil, too much Tylenol, etc. Tylenol is going to be less apt to cause that, but you have to have large amounts of them anyway. So let's go through these. So usually water and sodium loss and retention of acid will happen, okay, because those tissues are damaged. Now, the causes, once again, can be pyelonephritis. Now, pyelonephritis can be descending or ascending. Descending is going to be hematogenous. So we have some sort of bacteria that'll infect the cortex, then it'll descend through the cortex to the medulla along the urinary tract. That's not going to be as common as ascending pyelonephritis. Okay, that's much more common. And that's going to be some sort of infection. Usually E. coli is going to move, from the rectum. If a woman wipes, say, posterior to anterior, or she's not clean, she could get a spread of E. coli into the external urethral meatus. I think we all call it meatus. Now they're calling it orifice, interchangeable, whatever. Not whatever, but interchangeable. Okay, and that'll ascend, through the urethra, bladder, ureters, etc., all the way up to the kidneys. Okay, so either or. Now, And then it can cause damage if it's not taken care of, usually with ascending. Of course, women know it, and they're very uncomfortable when they get treatment. Can cause, oh, causes, I'm sorry, not causes. I was reading through that. Can cause pregnancy is what I thought I was going to say. No, causes can be kidney stones, prostatic enlargement, pregnancy, pelvic inflammatory disease, and tumors. Okay. Now, interstitial nephritis is usually toxic damage. You can have drugs, gout, polycythemia can cause swelling in those interstitial spaces. Okay, can cause damage. Now, this can cause eosinophilia. That's a pretty typical pathognomonic sign of it, and hematuria or proteinuria. Okay, as we mentioned earlier. So, renal vascular disorders. So, don't forget that a huge part of the kidney is getting the blood in and filtered. So, vascular damage from atherosclerosis from the aorta, renal arteries, circulatory shock, diabetic damage, glomerular capillaries can change that perfusion. That's a problem. Okay, so if we get nephrosclerosis or hardening of those arterioles because of systemic hypertension, and that could be a byproduct diabetes too, you could get a decrease in the lumen or that opening. It'll cause ischemia. That'll kick in renin angiotensin system. Okay, and that'll compound the problems. Microangiopathic hemolytic anemia. So when red blood cells, I don't think this is quite as common, but when red blood cells travel in hardened blood vessels, they can cause damage. That'll decrease the amount of red blood cells in the body, and those red blood cells cannot be replaced quickly enough, causing an anemia. The damaging of blood cells see, I'm telling you, I can't talk today. It's a good thing this is a short lecture. The damage of blood vessels sort of begins as an inflammatory process, but then what will happen is we'll actually deposit fats on the inside of those blood vessels, as you remember from the cardiovascular lecture. And as we deposit fats in there, they can harden. As they harden, they can damage those red blood cells and they can burst or open them. And we can get this microangiopathic hemolytic anemia. So that's what can happen there. Okay. So that was the physiology part of this lecture. I thank you guys so much. Once again, this is Dr. Deshavo. If you have any questions, I am happy to help. Let me know. Shoot me an email. I'd be happy to help you. Have a great day, guys.